In the last 15 to 20 years, there's been a massive expansion of non-invasive ventilation services across all hospitals in the UK. And the British Thoracic Society has run a national audit. Now there have been 3 cycles of this, which on each occasion have shown deteriorating results with worse mortality rates than expected. And there are other factors in the audit that have suggested that patients may be being treated too late with non-invasive ventilation, and that it may be that we're selecting different cases for treatment. And it was felt that the only way of answering the questions that the audit was raising was to do a detailed analysis of case notes in order to understand what the reasons were and come up with recommendations for improvement.
We looked at all patients aged 16 or over who were admitted as an emergency between the 1st of February and the 31st of March in 2015 who required acute NIV. We excluded patients if they had NIV at home or patients who had CPAP and not NIV. Unfortunately, both NIV and CPAP are coded the same, and they're 2 distinct treatments and should be coded separately. We collected data using a clinical questionnaire which went to the clinician responsible for the patient, an organisational questionnaire and a case note peer review. So we reviewed 353 case notes and we had 432 questionnaires returned.
It's shown that we need to be very careful in the selection of cases for treatment with NIV, that a significant proportion, up to a quarter of patients, have some form of delay in starting treatment, and so we need to be better at getting these patients onto treatment more rapidly. And there is room for improvement in both the ventilator management and non-ventilator managements. 70% of patients approximately have COPD. We need to be better at making sure they get access to controlled oxygen therapy, to nebulizers, to steroids as part of their overall treatment. And then the ventilator management itself needs to improve because a large percentage of patients don't have adequate pressures set on their ventilator, which is the key to CO2 elimination, which is what ventilation is all about.
We found that in almost a third of the cases, oxygen wasn't administered appropriately in the emergency department. And where it was documented, the method of oxygen delivery, only 17% stated that they used a Venturi mask. So we know that achieving appropriate target saturations and better controlled oxygen therapy could potentially reduce the need for NIV. In the respiratory wards, we found that only 80% of the wards were able to provide continuous oxygen saturation monitoring, and this of course is essential in titrating the oxygen delivery. Only half of the hospitals had a defined ratio of nurses to NIV patients, but I guess this is more of an organisational issue and not something that perhaps ward nurses can directly influence, but they can certainly challenge it. And I think specifically for all nurses, regardless of where they are, we know that there's inadequate documentation in over 50% of the cases reviewed, and we have some really good examples of prescription forms and NIV-specific observation charts. So nurses have a responsibility to complete these charts accurately, and they have a real opportunity for improving patient care.
So we know from the national guidelines that we would expect about 1 in 5 patients to be treated in critical care when they receive NIV. We know from our data that a high proportion of patients deteriorate during treatment with NIV, and therefore escalation of treatment may be needed. We also know from the organisational data that there are great differences between individual organisations, where some provide all their NIV in an intensive care environment or a critical care environment, and some provide none in that sort of environment. That doesn't necessarily matter as long as the environment where the treatment's being provided is an appropriate environment, staffed adequately and with the right skills to deliver treatment. But we should be expecting these patients to be treated in critical care. We also know that the patients have very high early warning scores. They've got grossly deranged physiology, and that associates with worse outcome.
I think what was interesting in the report was we discovered that in nearly half the cases, early warning scores weren't used, And where they were used, in about 56% of the cases, the patients were scoring 6 or more, indicating a need for urgent clinical review. And in 17% of the cases, they were actually scoring 9 or more, which indicates a need for critical care assessment. So we know that there isn't a standard common language throughout the UK at the moment, despite the recommendation from many reports.
And in that context, it's really important that we have an escalation plan in place for these patients, because we've already said they deteriorate quite frequently. And just as it's important to have an early warning score as a good communication tool to help people understand the degree of severity of illness of any individual patient, we also help communicate with the team on the next shift if we have a strong and identified escalation plan for these patients. I think there are a couple of things that stand out. Firstly, that we need to be accountable for the services that we're running. I've said that we're running services in almost every hospital, and there's been a massive expansion, and that's great if we know that the services are good services, but it's pointless if we're running a whole load of bad services across the UK. So local accountability is key, and I think that's about leadership, and we know from what we found in the study that most hospitals have a medical lead. In fact, most don't have a non-medical lead, but even the leads, when they have them, are not given any time to lead the service. And we also know that less than a quarter of hospitals actually count the number of ventilation episodes that they provide in their hospital, which really makes it impossible to plan your service. And quite worryingly, we found that up to 40% of hospitals had had a situation that they reported in 2015 where they had had more patients requiring ventilation than machines available. And if you're not counting the number of episodes, how can you possibly know the number of machines you really require? So some very simple things, and if it's as simple as just counting the number of episodes, that doesn't seem too difficult to implement. And then there's another organisational aspect, which is the system where taking the ventilator to the patient rather than having to move the patient around the hospital in order to receive ventilation seems to be a good model of care. And we know that 28% of patients that we reviewed in the study needed to be moved before they started ventilation. And we also know that a very high percentage, about a quarter of patients, had some sort of delay before they started ventilation treatment. And so there's definitely room for improvement by some very, very simple changes.
I think patients requiring NIV are mostly vulnerable, elderly and frail. So these patients require rapid assessment and frequent monitoring. So vital signs should be recorded hourly until the acidosis is resolved. But that takes me to my second key message, really. Because of their vulnerability and frailty, these patients do require one nurse to every 2 patients during the acute phase, which is an issue for organisations to address. And I think my third message is around documentation. Documentation of all changes is essential, and NCEPOD recommends using a standard pro forma.
Well, Gemma's already said that this is a group of frail patients who are vulnerable and who need to be monitored regularly. And I don't think we can overemphasise the importance of regular monitoring of these patients. So I too would say vital signs monitoring with adequate frequency is key to successful treatment. Secondly, inspiratory pressures are commonly set too low in these patients, and it's the inspiratory pressure that's key to delivering adequate ventilation. So we should stress the importance of pressure titration, increasing the pressure to deliver adequate ventilation. And finally, anyone who's involved in delivering NIV services needs to understand the factors that are associated with a successful outcome versus a poor outcome, because these factors should be really helpful in making decisions about who it's appropriate to ventilate, where it's appropriate to ventilate them, including whether escalation to a critical care environment is needed, and also how the ventilation is applied.